Most implant dentists believe improvement is automatic. More years, more cases, more experience. And yet, many reach a plateau and stay there. The idea that time alone leads to mastery has probably caused more stagnation in implant dentistry than lack of talent ever has. Because hours don't refine skill, they reinforce patterns. And if the pattern is flawed, 10,000 hours simply make the flaw permanent. Today, I want to explain why experience alone isn't enough and how implant mastery is actually built. Implant mastery is not about better hands, it's about understanding how the body responds to every decision you make. The original idea behind the 10-hour rule was never repetition, it was deliberate practice, focused effort, clear intent, feedback, correction. In implant dentistry, this does not mean placing implants endlessly and hoping experience fixes problems. It means reviewing cases honestly, understanding why something healed or didn't, and recognizing how surgical decisions triggered biologic responses. Two clinicians can place the same number of implants. One improves steadily, the other doesn't. The difference isn't talent, it's structure. Implant mastery isn't one skill, it's a system. 10 domains consistently determine outcomes: case selection and biologic risk assessment, diagnostic and prosthetic driven planning, sepsis control and surgical workflow discipline, soft tissue management and perfusion control, osteotomy precision, angulation, irrigation, heat, primary stability matched to bone biology, grafting and biomaterial behavior in living tissue, suturing and tension-free wound closure, post-operative monitoring and early intervention, prosthetic execution, load, passivity, occlusion. Ignore one and the system weakens. Respect all 10 and predictability follows. Deliberate practice doesn't mean practicing implant dentistry, it means practicing components, flap design, needle handling, knot symmetry, drill control, hand stability. This can be isolated and refined without pressure. Recording osteotomies, reviewing angulation and assessing closure at the end of surgery, not months later, accelerate learning dramatically. Without feedback, experience becomes repetition. With feedback, it becomes mastery. The case ladder is mainly relevant for implant dentists early in their journey. Early on, outcomes are rarely limited by hand skills. They're limited by pattern recognition. Green cases, single implants in healed ridges with thick tissue, reduce biologic noise. They let you see how tissue normally responds. Amber cases introduce controlled complexity. Red cases, thin biotypes, complex grafts, sinus lifts, full arch, combine multiple risks and are best approached with supervision. As experience grows, the ladder stops being a rule. It becomes a simple internal question. Is this a biologically quiet case or a noisy one? Not everyone needs a rigid practice routine, but if something doesn't feel automatic, small targeted practice helps. If suturing feels stressful, 15 to 20 minutes a few evenings a week changes that quickly. If planning feels rushed, prosthetically planning a couple of CBCTs each week sharpens judgment. If graft handling feels awkward, short bench sessions build familiarity. None of this is mandatory, but when improvement stalls, these are usually the levers that move it again. Improvement that isn't measured is assumed. Track simple markers: surgical time, tissue color and perfusion at closure, membrane exposure or dehiscence, primary stability trends, early inflammatory signals. Numbers remove ego. They show where refinement is actually needed. High volume without understanding increases risk. Work within biologic competence. Escalate cases deliberately. Slow down when outcomes demand it. Implant mastery is built, not gifted. If you're an implant dentist who wants biology-driven, complication-proof surgery, subscribe. Every week, we break down one clinical problem you've already seen in your practice.